Welcome to a special episode of the NRG Oncology Podcast, coming to you from the late-breaking abstract session of the 2026 annual meeting of the Society of Gynecologic Oncology in San Juan, Puerto Rico. We bring you results hot off the press from NRG-GY019 for low-grade serous ovarian cancers, presented by its principal investigator, Dr. Amanda Fader.
Dr. Fader, can you tell us more about these low-grade serous ovarian cancers? As I understand it, these are a minority of ovarian cancers and are far less aggressive than the run-of-the-mill ovarian cancer. What percent of ovarian cancers are low-grade serous carcinomas, and how does their biology differ from typical ovarian cancer?
Thank you so much, Dr. Shanahanke, for having me on your podcast and for this question. I'm really thrilled to be here at this moment of real momentum in rare tumor science through the NRG Oncology, as we're seeing more trials than ever moving through the pipeline and bringing new hope for better, more personalized care. And you're right that low-grade serous ovarian carcinoma accounts for about only 2% of all epithelial ovarian cancers and 10% of serous tumors. But in our rare tumor world, some of the rarest malignancies can have an outsized impact on poorer outcomes and mortality. And with patients who have advanced stage disease, outcomes can still be quite poor.
For ovarian cancers, typical management includes surgical removal of as much cancer as possible, followed by systemic therapy. One of the systemic therapies we use for low-grade serous ovarian cancers is letrozole, which is an aromatase inhibitor most commonly used in breast cancer, which works by blocking the body's production of estrogen. Is it fair to say that letrozole works for low-grade serous ovarian cancer in the same way in that it works in estrogen receptor-positive breast cancers?
So when we look at the molecular profile of low-grade serous ovarian carcinoma, these are indolent tumors that have very different protein and mutational expression compared to their high-grade serous ovarian carcinoma counterparts. And one of the predominant molecular features of these tumors is a very high rate of estrogen and progesterone receptor expression. Up to 85 to 90% of these tumors express estrogen receptors and about half express progesterone receptors. My colleagues at MD Anderson Cancer Center, Dr. David Gershenson and team, our rare tumor group at Johns Hopkins, and those at other centers have conducted several registry analyses and propensity matched analyses examining the role of both chemotherapy and aromatase inhibitor therapy, including letrozole, in patients with low-grade serous carcinoma. And all of those retrospective series have consistently shown sensitivity to endocrine therapy, and most commonly letrozole, and pretty favorable recurrence and survival data when endocrine therapy with letrozole is used either after chemotherapy and surgery or as frontline monotherapy following cytoreductive surgery. Because of these studies, the 2017 NCCN guidelines endorsed the use of endocrine therapy, most notably with aromatase inhibitors, in the treatment of advanced stage low-grade serous ovarian carcinoma. Despite these encouraging retrospective data, we really needed prospective randomized evidence to define the optimal frontline strategy for patients with this disease, and that's been lacking until now with the trial that I presented today, the NRG-GY019 trial, which is a randomized controlled trial. It's a 2-arm study of patients with stage 2 through 4 low-grade serous ovarian carcinoma who received either platinum taxane-based chemotherapy with carboplatin and paclitaxel, followed by letrozole maintenance therapy or letrozole monotherapy after cytoreductive surgery. And we then looked at how these patients did, what their remission rates were after these therapies.
The long-standing backbone of systemic therapy for most ovarian cancers has been the combination of two chemotherapies, carboplatin and paclitaxel. In low-grade serous ovarian cancers, we standardly add letrozole to carboplatin and paclitaxel because, as you've alluded to, these cancers are driven by estrogen. While I'd argue that carboplatin and paclitaxel have been the most important innovation for ovarian cancer in the past 3 decades, why are we trying to get away from carboplatin and paclitaxel in GY019?
The rationale is that low-grade serous ovarian carcinoma has historically demonstrated relative resistance to standard carboplatin and paclitaxel-containing regimens compared with those with high-grade serous ovarian carcinoma. when we look at several of the GOG and NRG oncology trials that included ovarian cancers, very few of those patients, fewer than 2 to 3%, have low-grade serous ovarian carcinoma. So a lot of the data that we've used to retrofit treatments for patients with rare tumors are really based on response rates in women who have the high-grade serous ovarian carcinoma. And the tumor type that we're studying in NRG-GY019, the low-grade serous carcinoma, is much more indolent. We've learned that only a subset of patients with this disease really are exquisitely responsive to this chemotherapy regimen. And in looking at the neoadjuvant chemotherapy studies done in low-grade serous from MD Anderson Cancer Center, we learned that there was only a 4% response rate to that chemotherapy regimen in that setting. And then when we added to that the retrospective series of looking at either letrozole monotherapy or letrozole in conjunction with chemotherapy, as well as population-based data from both Germany and the United States and elsewhere to sort of see what are response rates to chemotherapy, there was questionable response in the entire population. And so we really wanted to conduct a de-escalation trial instead of a one-size-fits-all. Can you safely avoid the toxicities of chemotherapy in this population?
So with all of this in mind, what are the results of GY019 presented today at the late-breaking abstract session of the Society of Gynecologic Oncology? And how do these results impact the national or international standard of care for low-grade serous ovarian cancer moving forward?
We analyzed efficacy and conducted safety analysis on all treated patients. And what we found in the 450 patients that were enrolled, most patients were in their early 50s, had a pretty good clinical performance status. Most were enrolled in North America, and the majority of patients in the trial had stage 3 disease, and 64%, actually the majority, underwent surgery where no obvious remaining disease was found at the end of the surgery. And when we looked at the results for what's called progression-free survival, or the disease not coming back or progressing during the time once the treatment starts after surgery, the hazard ratio for letrozole versus chemo plus letrozole in this population was 1.30. And so what this basically means was that letrozole was not found to be non-inferior to the chemotherapy in the letrozole, even though the difference in the remission rates or the progression-free survival rates was not statistically significantly different between the two treatment arms.
So actually, if I can stop you just one second,
Yeah.
one thing that I think can really confuse a lot of people out there is the kind of double negative when we say not non-inferior.
Yes.
I used to get confused about this all the time. I think I still get confused about it, to be honest. When you're saying not non-inferior, are we essentially saying it was inferior in that case?
Not necessarily that it's inferior, but that we cannot definitively prove that it's not inferior or non-inferior.
Equivalent. So basically we're
Correct.
saying, we don't know whether just doing letrozole alone was equivalent to
Correct.
the combination of all three.
Correct. There was a concern based on the trends in the recurrence patterns that we were seeing in the trial that more patients in the letrozole arm had experienced recurrence events. It was about 13 more patients at the time that the data was analyzed than in the arm with the chemotherapy plus the letrozole. And so at the time that the trial closed, about 77% of patients with the chemo and the letrozole were still alive without a recurrence of their disease. About 72% of patients with the letrozole remained alive and progression-free. Patients in both arms have experienced pretty high survival rates overall, with 95% overall survival or patients still alive in the chemotherapy and letrozole arm, and about 92% in the letrozole monotherapy arm. What's interesting and complex about these results is twofold. Not surprisingly, the adverse events or the side effect profile of the patients who received chemotherapy was quite a bit worse. And this excess toxicity was primarily decreases in cell counts in white blood cells, red blood cells, and platelets, and also some notable increases in side effects to the GI tract and neuropathy in patients. But one of the stratification we used in the trial is that we wanted to make sure we had pretty equal numbers in both patient arms of women who'd undergone surgery where all the disease was grossly removed, that the surgeon felt like they had gotten all the disease they could see with the naked eye out. And that was about 64% of patients in this study. What we found in this analysis is that the hazard ratio for progression of disease or having a recurrence event in this population was much different than what we saw in the overall cohort. The hazard for progression was only 1.15 in this population, and the progression-free survival was not statistically significantly different between the treatment arms. In fact, there was only 2 more progression events in the letrozole, in the patients who received letrozole compared to those who received chemoletrozole. And so that post-hoc analysis, it was really provocative and basically suggesting that although hypothesis generating at this time, it raises the possibility that a clinically relevant subset of patients may be appropriate candidates for letrozole monotherapy. If we look at the safety advantage of endocrine therapy compared to chemotherapy and this exploratory signal, could some patients with no gross residual disease after surgery be carefully selected to receive endocrine monotherapy with the letrozole? We don't know that answer yet. This is really provocative data, and we have ongoing clinical follow-up now and planned translational tumor analyses to better contextualize these findings and really clarify which patients derive the greatest benefit from the chemotherapy.
As you've already talked about, I noticed that the survival was pretty good in both groups.
Yes.
95% and 92% respectively. I wanted to ask, do you have any sense of how many patients who were assigned to letrozole alone went on to receive carboplatin and paclitaxel as salvage? And specifically, what do you say to a patient out there who wants to avoid many of these side effects you just talked about and who just says, well, why don't we just start off with the letrozole and add the chemotherapy later if there's progression?
So that's a great question that we are currently doing some additional subgroup analyses on to determine if patients received carboplatin paclitaxel after progressing on letrozole monotherapy, and we'll have some of that data for you in the near future.
While across the board in non-selected patients, the results of GY019 didn't seem to support the omission of chemotherapy, are there possible opportunities to pursue this paradigm in better selected patients? I think of estrogen receptor positive breast cancers where we use things like Oncotype to analyze tumor molecular profiles to make decisions about whether or not to omit chemotherapy. Could something like that even be in the cards for patients with these kinds of tumors in the future?
It's an excellent point and something that we strive to elucidate. I think this trial was practice defining for several reasons. We'd never really truly established the standard of care in the front line for patients with low-grade serous ovarian carcinoma. This is the first phase 3 frontline trial in this rare ovarian cancer type, as well as the first rare ovarian epithelial cancer trial to complete enrollment in the frontline setting. And it really proved that cooperative group sites and community and academic oncologists can successfully recruit patients to studies of rare tumors. I also think it demonstrated that using the best available evidence with careful attention to cooperative group practice realities and substantial input from patient advocates was important. And I wanted to point out how much patient advocacy, as we were designing this trial, was critical here in listening to women and understanding what their concerns were about chemotherapy and its efficacy and its toxicities. And patients really drove this. And we were so proud to work with so many thoughtful and talented patient advocates who helped us really think about this in a different way, as we've seen in breast cancer as well, as you mentioned. And so, yes, one of the ongoing correlative analyses we're doing is really understanding the endocrine receptor profile of these tumors and whether degree of estrogen and especially progesterone receptor expression really matters here. There's some retrospective data, from the MD Anderson group as well, suggesting that when you have low progesterone receptor expression, that responses are not as high to aromatase inhibitor therapy. We're looking at the impact of residual disease because we know that more patients who experienced recurrences had that measurable disease or didn't have all of their disease removed at the time of surgery. And so really looking at both the cytoreductive surgery status and the estrogen and progesterone and other molecular profiles of the tumor, including KRAS mutations, et cetera, can really help us, I think.
Before we wrap things up, for big cooperative group trials like GY019, we always like to give our principal investigators the chance to recognize key members of the team. Who were the heavy lifters for GY19 who deserve special recognition in making this happen?
That's so lovely that we're doing that. I mean, I think first of all, would like to thank the patients and their families who put their trust in all of us and all of the investigators and enrolled on this trial and allowed us to care for them. I think behind every data point and survival curve is a human being, and I want to first express that deep gratitude to the patients. But also, one of my mentors and closest collaborators, Dr. David Gershenson, who is the co-principal investigator of this trial, was instrumental. Dr. Austin Miller, our NRG-oncology statistician, developed a wonderful design. Dr. Carol Agajanian, Dr. Elise Cohn, who helped us move this trial to the forefront and helped us again and create an opportunity where this is the first rare ovarian cancer trial to complete enrollment that we think ever in the cooperative group worldwide. So in that sense, it's quite a milestone. And the amazing NCI staff and NRG Oncology staff and leadership, research teams, co-authors, and my international co-PI, Dr. Lillian Guillen from Toronto, who made this trial possible. I really could not have done this without this incredible and collective who really believes so strongly in this. Finally, I would just say the NRG Oncology Rare Tumor Group that is now currently led by Dr. Al Covens and Jubilee Brown were just pivotal in providing us the support.
Dr. Fader, truly huge congratulations on completing this trial and on your presentation of NRG-GY019 at the late-breaking abstract session at the Society of Gynecologic Oncology. And thanks for coming on the NRG Oncology podcast with us to share these results.
It's been an honor. Thank you for inviting me.
Today, our guest on the NRG Oncology podcast was Dr. Amanda Fader, speaking about the results of NRG Oncology GY019 presented today at the 2026 annual meeting of the Society of Gynecologic Oncology. If you haven't yet, you can follow or subscribe to the NRG Oncology podcast wherever you get your podcasts, especially with the SGO annual meeting right around the corner. The NRG Oncology Group is supported by funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks everyone for tuning in, and happy clinical trials.